So if we were to do this, explain to me the process. Say here, if I were to send you a check for roughly $5,000, how many ounces would that be? Okay. And where I can't get a partial amount of that, what happens to that other? You just credit that back. Okay. Pardon? Okay. 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 So the price when I go on commodities, you know, like when I'm looking at the stocks, that price for silver is for like coins and stuff like that, not just raw silver. No, I understand that. Can we do that through a debit card? Okay. Okay, personal check. And then sell that. I paid, you know, let's say you said it's probably $30 right now. If I were selling today, what would I get for it? So I got 5%. That's where I paid. So I get 30. If I paid 30 and turned around and sold it, I could get 30 minus 5%. Okay. So can you got my email? What do you guys do? Right. So, gonna explain that process on your email to me and talk to my spouse. You know, decide how much we're gonna do around the first time. And, see if we can get this process rolling. Is there any other before the election, is that? And
So I'm not sure what else I have to do, because when I hit the record button, it says, please request recording permission from the meeting host. So I did send that to you, but I don't know if there's something on your end that you have to do, because it still won't let me record it. Okay. Right, and I see that it's going now, and then on the bottom, it said record, and that's when I hit it, and that's when it said you must have permission from your host to record this. So I don't know. I don't know that much about it. That's like my thought. I'd just call you instead of just typing you and letting you know what it says. Do you want me to? Well, you probably can't see what comes up on my screen, can you? Okay. Yeah, it just says, please request recording permission from the meeting host. Okay. Well, I can see on my screen that you're recording it. And so, okay. Chances are if I get called in, which I probably will, I thought I was going to get called in last night, but I didn't, and they're not going to let her go another night. But if I get called in at 6:30, chances are I probably won't get back before we're done here. Because usually by the time I get everything done, it's usually 2 to 3 hours.
All right, everybody, it's 6:30. I'm going to go ahead and kind of get started. So welcome back. I just want to check, make sure everybody can hear me okay. Awesome. Okay. So if you guys didn't fill out the poll, obviously I started a little poll for you guys. Just wondering about your guys' general knowledge of the KIMS program. Looks like some of you guys have heard a little bit about it. A couple of you guys really have no knowledge of it. And then I don't see anybody that's like a KIMS guru yet. So hopefully by the end of this, you guys will be KIMS guru. You know, do you feel like
Except for I cannot hear Travis.
Kim, I think you're the only one that can't hear me. Give me just a second, guys. Let me yell at Kim. All right, awesome. So we'll continue. I did put out another poll and I didn't see it come up, but I was just curious, and we can do it next time, but I was just curious what your guys' thoughts are with actually implementing a CHEMS program in the future. And so we'll kind of talk about that more if I can get that other poll to come up. So with that, let's go ahead and I'm going to share my screen. And with that, you guys should be able to see a screen that says Community Health EMS. Is that correct? Awesome. All right. So this is kind of the module that just goes in kind of an introduction of Community Health EMS, where it kind of came from and why we decided to move this direction as a EMS community. So the first thing I want to kind of touch into is just what is the definition of Community Health EMS? I think we're all pretty knowledgeable of what EMS is. We get called by 911, we respond as fast as we can, and we treat people for about 20 minutes, which is about our breaking point to be with certain patients, and then we drop them off at the hospital. And I think over the years of doing this, we have all kind of realized that is there something more we can do. A lot of us go into a home and see that grandma doesn't have the best food in her house for her being a diabetic, or grandma has a bunch of fall risk within her house. And I think we've always kind of just said to ourselves, there could be more that we could do, but we never followed through with it. And so kind of the idea of Community Health EMS is to create that non-emergency type role, moving from the quick response to more of a, how can we help these people and manage their chronic issues? And the way we do that is we kind of find the gaps within, the healthcare community. And that's the big focus on Community EMS, is to find the gaps within your community, within maybe even the person's home, and then use us as a way to solve those gaps. So we need to also be evolving to keep up with the changes in reimbursement. Our next module today, we'll actually talk about some of the billing and kind of how EMS bills now versus how things are going to probably look in the future. We're definitely moving away from that fee for service. So right now, we only get paid if we provide the service, right? If we're just sitting there not running calls, we're not getting paid. But so we've strived on telling people, hey, I know that's just a finger laceration, but if you don't go into the ER, you're probably going to die, because we wanted to get that payment from that transport. And we all know in reality that, 97% of what we do is not emergent at all. So I think as time goes on, they're starting to learn more and more that, that is true. And the emergency room is also being overutilized. We'll kind of go into that details a little bit more, and how potentially we could be the first step to saving a lot of that unnecessary ER utilization. They also realized that EMS providers could be an extension of the primary care physician. We are very well trained as EMS providers. We've become one of those people that can evaluate and treat people without having all the labs, all the x-rays, and all those things that they have in the ER, and that's a skill that I think physicians have kind of lost overall, is being able to look at a patient and kind of determine what's wrong with them, and how we need to treat them. And so it's kind of nice that we have that ability to be kind of an extension of that primary care and help provide better service to their patients. And then also just look into all aspects of patient care. There are definitely spots where you guys know that somebody may not qualify for home health or hospice, but they definitely need some assistance at the home. And so is that something that we can do to fill that gap to help out? Now hopefully our positions are just a short term. Obviously we don't want to be in those homes for months or years on end doing help for stuff that we're not necessarily getting paid for. But can we fill that gap to help get those people in the right direction of what they need for help? Does anybody else have any thoughts or ideas of some gaps that you see when you're transporting patients or dealing with people within your community? And this is the part where you guys get to unmute yourselves and talk.
I would say that one of the things that this is about the only thing that, to a point, that we're doing chems in our community is we have a nursing home that has a pretty large apartment that is alternating floors of independent and then assisted living floors. And we were going there at 2 a.m. for falls very, very frequently. And it was a 911 call for someone on the floor because the CNAs are not allowed to do assessments or pick the patient up. And so we were filling an ambulance crew just to go pick up someone off the floor that wasn't injured. And so that's where our paramedic that's on call is now on call for Good Sam and provides that service. The CNAs can make a phone call if they don't believe there's an injury. And so for us, it was burning out our volunteers to get up at 2 a.m. to go pick up the same lady who we knew most likely wasn't gonna be injured, or maybe she was soiled and, still on the floor. So that was one of our gaps that we filled with this. That's just a start. And then the nursing home pays us a fee for that.
That's super awesome that you were able to get them to pay you a fee for that. So as most of us know, ground level falls and lift assist are something that normally aren't paid for. And so just as you said, you're sending a crew out there, you're paying people money, and taking away from the volunteer service that, doesn't have a lot of money in the beginning. I know a lot of you, I don't know if all of you are paid volunteers, but I know a lot of you are. And, as you start paying for those unnecessary calls, that definitely can take a toll on your ambulance service. That's, maybe some new equipment or some other things that would definitely help you guys out a little bit more. I think that's a really, really good example. Can anybody think of any other good examples of some gaps that you've noticed that maybe you can utilize chems for?
I think just a lack of education in the public. There's a lot of times where just explaining to people that what you've got is not 911 call worthy or emergency room worthy, and just letting them understand why that yes, you see blood and it's an emergency to you, but here's why it's not. It can be handled at home, and just working with people on just education alone, I think, is a huge gap.
Yeah, and I think to your point, we're trying to slowly work our way to that exact thing. If you guys haven't heard of ET3, we'll talk about it later. But ET3 is kind of that direction of, can we treat and release at the home and at least get some payment back, because we're going to save the hospital, we're going to save the patient, we're going to save their insurance company so much more money. If exactly, like, this isn't really a true emergency. Like, yeah, I understand you need somebody to look at it and tell you, because not everybody's as educated as we are, right? We kind of get that stigma of it's like, why is this person calling? This is the stupidest reason ever, and why don't they know better? But I can guarantee you, if I started talking IT tech to you guys about networking and security and all that stuff, it's going to be over half your guys' heads, and you're going to be, and that guy that probably works for IT is probably like, what is this guy doing calling me to install this antivirus on his computer? Why can't he do this himself, right? So we all, as people, tend to fall into this habit of, why are they calling us, or why are they not educated? Well, your point exactly. Maybe they've never been taught, or maybe they just don't know because it's not their specialty. And I can tell you there's a lot of things out there in the world I know very little about. And people probably think I'm an idiot because I don't know. But at the same time, there's a lot of things that I know a lot about. And so we just have to put ourselves in their shoes and their perspective. So good point. I think the last thing that I would kind of talk about is gaps is just mental health, and especially in the rural communities. Mental health is very poor managed. There's very little help for mental health. And I think this is where the community paramedicine or the chems program could be a good function, or a good barrier to that gap, or a good bridge to that gap, I guess is the way I should say it. Ada County paramedics down here, and we'll kind of go into their programs a little bit later also. I know I keep saying we'll talk about it later, and you guys, I promise I will. But they do have a community paramedic program focused just on behavioral health. And so they have a paramedic that's staffed during their peak times. It's not 24 hours a day, but during their peak times, that respond with law enforcement and help find patients a place to go instead of just dump them on the jail or dump them on the hospital. And they've shown that that saved a lot of money for the county. And so it's been a pretty successful program. And I think it's partly the most successful program in their chems program right now. They've tried some different things, and that one's done probably the most good out of everything they've done. All right. So next, we kind of just talk about our problems for our hospitals, right? And we kind of touched on this a little bit, but the revolving door, we all know about it. People use the emergency departments as their primary care doctors. You know, it's convenient. There's somebody there all the time. They don't have to schedule an appointment. How many times have you guys called? And maybe not so much in smaller towns, but definitely in the bigger towns, you call a doctor and they're 2, 3, 4 weeks out before they can even see you. And you're like, but my problem is now. I need to see a doctor now. You know, may not need to see them today, but I need to see them sooner than 4 weeks out. And so we've created this huge problem for ourselves where the hospitals have become a revolving door and we're overutilizing the ERs. There's also some problems for the hospitals for uncompensated care, and they actually get penalties for it. So now they're talking about, hey, if you discharge somebody with congestive heart failure and they come back within 30 days and get readmitted into that hospital, that you don't get any payment for that readmission. And so that is a huge amount of money that the hospitals are losing, right? And that their Medicare and all those guys are thinking about doing this for not just CHF, but other medical problems. But CHF was the big one that they were really pushing. I'm sure here before too long, it'll be the same with sepsis. You know, you send somebody out of the hospital with sepsis and they return within 30 days, it's on the hospital now. And you can imagine how much money that's going to cost. ED overcrowding, probably not as big a problem in Idaho as around the rest of the country. But we've all heard those stories of people waiting out in the ER lobbies for hours, up to, 10, 15, 20 hours waiting to see somebody. A lot of that has to do with the revolving door and the misutilization of that emergency department. Places like LA and Chicago and New York, they have a lot of, I call them urban explorers, or, the indigent people that tend to be sent to the ER when nobody knows what else to do with them. And so they're overcrowding the ER and making it harder for them to actually take the time to treat the people that really need the emergency room. Also, another problem with hospitals is increased wait times. And that once again goes with the overcrowding. But one of the coolest things that we have down here is West Valley actually has a board next to the freeway, and it actually says their ER wait time. And so they use it as kind of a selling tool because people are driving home. They're like, oh, the wait time at West Valley is only 10 minutes. Great. I'm going to go there to go get seen instead of St. Luke's. It's, I can never get in fast enough. It's kind of the wrong idea, but once again, the hospital wants to make money, so I get why they do it. But you can just drive by that board, and certain hours during the day, they have 90 minutes to, 120 minutes of wait time to even just be brought back to the ER to see a doctor. So that's just crazy. Increased cost of healthcare. Everything in healthcare is more expensive, right? You see your hospital bill when you go to the hospital and they charge you $50 for an aspirin, and that's their way of recouping for all those people that never made payment, or the people that, faulted on their payments. Or as the increased cost of healthcare goes up, the amount of money that they're being reimbursed is going down. So Medicaid is notorious for this. They'll continue to drop the pricing to the hospitals and expect more of treatment. And so that's very frustrating to hospitals. And so what they have to do is push that cost onto you guys, or I should say the insured. I'm assuming you're all insured, but I probably shouldn't assume. But they push that off into the insured people. And so that's just increasing the cost for everybody. And we also know that since we've done healthcare for all, our medical insurance has gone up and our deductibles have gone up. So there's no way we're winning this war right now. And then the other problem is just limited connectivity with primary care physicians. This is 2020 and we're a society of being connected via the internet, but yet a primary care doctor and a hospital rarely talk to each other, and we'll get into this a little bit more about health data exchange, but I don't understand why this is a problem. We should be able to talk. We should be able to see that that patient was just down the road getting narcotics from, their primary care doctor, and they're searching them again here at the ER, or, they've been to 6 different ERs in the last 3 months. But it's not easy to do that. Hospital systems do not like to share information. They continue to hold on to their information. And so I don't think we're doing a service to our patients or our communities by doing that. And as we all know, are we really being open with the hospitals? Do we have open communications with the hospitals on what we do? And so that's going to be a big thing as we move into the future is why aren't we communicating more with the hospitals? Why wouldn't the hospital know that we've been out on Linda 16 times in the last, not Linda Fox, obviously. Sorry, Linda. It was just a name I brought up. But, why are we on Linda 16 times for ground level falls, and why is that not going back to the hospital or to the primary care doctor so they can solve that problem? And so, it's crazy to me that we're not having those conversations. Any questions so far? Still doing good? Not boring y'all yet? All right. So next one is the problem for patients. We kind of talked about this briefly, but it's expensive nowadays. As the prices go up, healthcare companies are paying less and less. And there's even been some talk recently of people going in the ER and their insurance companies reviewing their visit and then going back and saying that wasn't justifiable for an ER, so we're not going to pay for it. Well, that's kind of crazy to me because if your patient was like, I felt like this was a true emergency and I was sent to the ER and they fixed me, but yet you're saying it wasn't justifiable for an emergency room. That kind of can take a big chunk out of people's income, right? On top of that, a lot of our patients are already on limited incomes. Betty, 80 years old, she's on Medicare, she barely can afford her house. And then every time she goes and utilizes the hospital or her doctor, she has to pay a copay. And so, being on a limited income, that $20 just to go see her physician may be too much. Problem for patients right now is the exposure to healthcare infections. We all know this with COVID. Everybody's afraid to go to the hospital. And when they do go in, there's a higher risk that they will contract something. We've all heard of hospital induced staph infections because they're in the hospital where there's a lot of sick people, and we, as much as we try to make sure we switch gloves and clean our hands and make sure we do the clean stuff, it still puts them at risk to obtain an infection. And then with the increase of COVID, how do we not know that we're not transferring COVID from one patient to the next? We can wear as much PPE as we want. We can try to be as hygienic as we want, but necessarily that just gives them an increased risk. And especially if they're already in the hospital, is that risk going to end up killing that patient if they get it? And then the increased risk of medical mistakes. Obviously, anytime you go to the hospital, there's a chance that they may screw up. They might cut off the wrong arm or the wrong leg, or it's notorious to hear that a doctor or a nurse, I should say, has pushed the wrong amount of medications that have caused harm to patients. And so, we don't really want the patients to be going to the hospital if they don't necessarily need to. All right. So this is kind of the history of community health EMS. It's not real exciting, but we got to talk about it. So kind of understand how it all started and where it came about. So this all kind of started in Red River. There was a project. Red River is in, I believe, New Mexico, if I remember right. And what had happened was they had a huge physicians shortage. They didn't have enough physicians to patients. And so they decided, well, why don't we give our paramedics an extended role and allow them to perform some duties that maybe, a physician can do. And so these paramedics were given this thing for about 5 years. During this time, they also pushed to get more and more physicians into the area. And then eventually the program actually dissolved because they got enough physicians to move into the area to take care of those patients. But this was kind of the first time the term community paramedicine was really used. Next, we have this wonderful article by Thomas Raleigh, and it was actually interviewed by this Kevin McGinnis, and it kind of focused on rural agencies and the struggle that rural agencies have. They talk about the high cost to have an ambulance service within, a small town, but yet the low call volume. And how do we get paid again? We get paid by the number of calls we do. So how do we keep these things alive? And so this whole article, which was, I can't remember what year it was actually written. Let's see if we can bring it up on my computer here. Is all about how we can change the rural departments by utilizing community paramedicine and utilizing them for another reason other than just, for 911 calls. And so pretty long article, as you can see. I'm kind of going through it. I think it's about 16 pages, but it's actually got some really good information in it. So when we get done here, I'll send this out in an email with the link, and you guys can review it if you want. All right. Next came to the Rule and Frontier report. This was a 100-page report that the EMS Commission put together, kind of talking about the current state of EMS and kind of the future of EMS. And in here, they kind of talk about community paramedicine and how they believe in order to maintain EMS within the country, we're going to have to do something different. The way we're doing it now is not sustainable, especially in the rural area. And they identify the crisis in there. They do an agenda for the future every couple of years. And I think there's actually a newer edition out than what I have on here. These things are very long, they're very in depth. Somebody gets paid a lot of money to research it, but if you really are interested in kind of how they predict what's going to happen in the future of EMS, I would definitely read these. And then they've developed these for years and years and years and are pretty accurate in what they've come up with. And here's the actual agenda of the future. And basically their exact quote was, EMS of the future will be community-based health management, which is fully integrated with the overall healthcare system. So we're no longer by ourselves. We're no longer the lone wolves that just show up, drop people off, and there's no more integration. It's going to be us talking to the hospitals using that health data exchange and kind of being one with the hospitals back and forth. And then another really good thing that's kind of pushed the community paramedicine is the International Roundtable of Community Paramedicine. They meet every year except for the year of COVID. They meet from people all over the United States, or all over the world, from Australia to England to Canada, and they just talk about different programs, different ideas, and all things community health. And so I actually brought up their webpage. It's ircp.info, and they have some really good resources. There's even a whole thing on their webinar, every single webinar that they've ever put on. And so if you guys want to learn how other people are doing things in other countries, this is a great opportunity to go over this. This website also has different downloads of stuff that you guys can pull from them, from general articles to, performance evaluation, to research, to tools and data sets. And so as you start to develop a community paramedicine program within your agency, you're going to want to refer to some of this stuff, because data is going to be very important. We got to collect the data. We got to prove that it's doing something, or else we're not going to get paid for it. All right, so just talking about some national programs. The first one I'm going to touch is just some programs that we've had here in Idaho. And so a couple of years ago, they started a SHIP program. And basically what this is they were allowing agencies to participate in this. And what they did is they paid a certain amount of money to get EMTs, paramedics trained to the community paramedic level. This happened, I believe, for 5 years. And we trained paramedics from Ada, Canyon, Paramedic, Bonner, Boundary County. And then they paid a little bit of money. I think it was $9,999 to help create a program. And so that consisted of a few things. It consisted of buying people laptops so they could go mobile. It helped them with some materials and some paperwork. And it just helped kind of push the community paramedic into Idaho. The unfortunate part is with anything is with grants, it's great to have, but if you don't have a sustainable model, it's all going to dissolve, right? And so probably the biggest mistake with SHIP is they didn't look after the 5 years. And so by the time the SHIP grant was over, there was nobody paying for the services. And so now the EMS agencies were responsible for paying, or putting on those programs by themselves without being able to bill that out to anybody. And so I helped create the Payette County community EMS program. We did well for about 2 years, and then obviously the money dried out. We had to shut her down. So it's kind of the frustrating part about all this. I know the state is still working really hard on trying to get some payment models, and they actually gave some money over to Lincoln County to do kind of a pilot program with community EMTs that are partnered with a clinic within their area. And from what it sounds like, it's very successful. And this could be a start to that lead of being able to bill for it, because I think they're in talks with Blue Cross, Blue Shield, and some other insurance companies. So that's super exciting. And we may actually, I may reach out to Mark, who is the EMS director out there, and just have him come talk to you guys about what's going on with their program out there, what their successes are and what their faults are. Nationally, in the year 2015, they had 33 states that reported programs. Minnesota was the first to establish licensing in community paramedicine. And then some notable programs, if you guys ever want to learn some good stuff about programs, Eagle County EMS, they are a very rural area EMS group out of Colorado, and they have done amazing things with community paramedicine. That would definitely be a good way to kind of see what they're doing as a rural agency, right? See how you can kind of copy with their success. MedStar and More Mobile's another one. The Ethan Project, Minnesota EMS, and then REMSA out of Reno. They've done some great stuff with, they're pretty much the people that started ET3, the reimbursement for not transporting, and they're going to be a huge influence into whether or not ET3 is successful in the next 5 years. All right. So there's kind of 11 steps to help define whether or not you have a successful program. And you kind of want to follow these steps in order to make sure that you don't fall on your face and mess up. So step number 1 is just be fully integrated. We kind of talked about this, but they want your information to be bi-directional. Without that information, it's not going to work. Probably one of the biggest struggles we had out at Payette was that the physician's office wanted our information. They wanted everything from us, but they wouldn't talk back to us. And so we really didn't have that bi-directional sharing of information. And so I'll send a referral over to the doctor and say, hey, we're concerned about this patient. And then that was pretty much where it went. We don't know if they actually followed through with it. We don't know if there was something else that we could do to help move it forward. And so I think the advantage of being in a smaller community is you guys know your doctors. You don't have a lot of them. And I think you could kind of build that bi-directional sharing of the information. Probably the reason that Lincoln County is so successful is they have one clinic out there, and that's it. Every patient goes to that clinic. And so they kind of have that bi-directional sharing, and then they actually chart on the clinic's charting system. So they don't actually use their own separate charting system. They use the clinics. And so that I think is super helpful. So they're actually going out, doing exams, doing evaluations of the homes, and then able to report that directly to the doctor. And then when the doctor sees that patient next, they can cover some of those concerns that those paramedics had. Collaborative. This basically is focusing on making sure that you talk to your community and what the needs are, right? If you just go out there and you say, I'm going to create a community paramedic program based on mental health, right? Because you think that mental health is a problem. But really, in reality, in your community, it's not a huge problem. Then you're just wasting your time. And so you need to work together with your community leaders, which includes the hospitals, probably your commissioners, city council members, anybody that is directly related with the community, and talk to them and say, where are your gaps? Where are the problems? A lot of hospitals will put on what they call a community needs assessment, and they'll base the way that they move forward within their hospital towards those needs assessments. And you can pull those from most hospitals. We were able to pull some from St. Luke's and from St. Al's, Ontario, when we did our community paramedic program, and use those to identify some of the needs that they had. And then now you're a good selling point to the hospitals, right? Because now you can say, hey, I see you have this huge gap, and we're ready to fix that gap for you. And this is how we're going to do it. And they'll be ecstatic. And that's where you're going to get people to want to buy into your programs. Any questions on that? Cool. So supplemental, this is where you guys are going to be enhancing existing healthcare systems. My example to this would be when I walked into the home of a lot of people's houses, the first thing they said is, we don't have insurance. Okay, well, why don't you have insurance? Well, the last time I applied for Medicaid, they denied it. Well, how long ago was that? 10 years ago. I'm like, well, why don't we reapply? Because things have changed. You're sick, you're unable to afford your health care, you can barely afford food in your refrigerator, you know. Um, Things have changed, rent has gone up, your amount of money for your Social Security has gone down. And so what we were doing to enhance the healthcare system was we spent a lot of time helping people fill out Medicaid paperwork. And then on top of that, to explain to them that there's a Medicaid expansion, right? There's more people out there that can access Medicare or Medicaid, sorry. Being able to help them obtain those resources has been great. Some other things is just as simple as Meals on Wheels. A lot of people don't even know they qualify for it. They don't know that it's maybe in their community. And there's just all these resources out there that you guys should be out looking for, that'll help meet those needs of those patients. We were able to find a lot of resources within Payette County, and then I was able to kind of direct those people towards those. And I think that was probably the biggest help to 99% of our patients, especially that connection with Medicaid. I had a poor guy that was a congestive heart failure patient that couldn't afford his ambulance bills, and he was like, even if I get Medicaid, who cares? Because I still have all these bills, from when I went into the hospital. I sat down and explained to him, I said, a lot of times Medicaid will go back 60 days. And so the faster we file this, the less chance that you're going to be responsible for that $3,000 or $10,000 worth of bills that you have. And so we were able to get him on Medicaid, and that was a huge help to him because he no longer was stressing about those ambulance bills and those hospital bills from when he got really sick. All right, number 4, data driven. You guys are going to hear this a lot from me. Data is important. We can say till we're blue in the face that yes, community paramedicine makes a difference, but until we can prove it, nobody's going to believe us. Okay, so we need to make sure that when we are collecting data, that we're collecting good data, measurable data, and making sure that we're benchmarking the opportunities that we have. And so a lot of times what we'll do is build before you start actually seeing patients. We'll actually build kind of a matrix of what we want to track. And if you guys are mostly on Idaho Perks, there's a good way to do that within Perks. You can make worksheets, you can make certain forms that you guys always fill out, and Perks allows you to pull data on those forms when you make them. And so that would be a great opportunity for you to build your charting program to your data that you want to collect. And make it a lot easier when you want to run a report, because then you're not counting, you're just hitting run report and it makes it for you. So patient-centered, very important. We need to make sure that we're focused on improvement of the patient outcomes. Not everything that we do in healthcare is always positive patient outcomes. So what we need to do is collect the data and make sure what we are doing is improving their outcomes. If we're doing falls assessments on people, that's nice. But if they keep falling, we're really not proving anything, right? And so we need to make sure that what we're doing is actually improving their outcomes. Recognize as multidisciplinary. This is kind of where that talking with doctors are, being engaged, being interactive with other practitioners, including mental health workers, social workers. And we need to be part of the patient's primary or their medical home. And so you'll often hear this as patient-centered medical home, where everybody works together with the patient being the center of the focus. This is also probably a good opportunity to utilize telemedicine to be able to bridge or to bridge that gap between us, talking between practitioners and us. We're in the world where we're moving to 5G on a lot of our cell phone networks. This is going to be a great opportunity for us to utilize programs like Zoom. There's HIPAA controlled Zoom meetings that you can set up. And so, this is a great opportunity where maybe the patient can't come in and see the doctor, but we can bridge that gap. Team-based. We need to work together as a team in order to continue to meet the needs of the patients. And I think this kind of mixes in with interdisciplinary, but it also works with our team too. We have to integrate all of our providers to be on the same page. And so if you have a multi-response team like police officers, fire departments, and EMS that all go to a call, we need to work together in order to meet the needs of those patients. And so the fire department should be very knowledgeable in your community paramedic program and know how they can utilize it. And the same thing with police departments, because we're not always the first people that are there. For some of you guys, it would be your QRUs that are around, you know, making sure that they understand what you guys provide and what they can do and how we can improve. Educationally appropriate. We need to make sure that before we go out and start doing community paramedicine or chems, that we're educating ourselves in the programs, making sure that we show that we have some higher standard to be able to provide that care. I know one of the things that the state was looking at was whether or not they want to implement that we take a national standardization test to make sure that we are compliant with it. I don't necessarily disagree with that at all. I think it's a good approach, but there needs to be a national standard for it first. So there is a community paramedic test. There is not a community EMT test nationally yet. I know they're in the process of talking about doing that and creating that, but definitely something that I think we need to show is that, yeah, we have taken this extra education or we have taken this extra step to be able to provide this care. Consistent with the triple aim. I don't know how many people know what the triple aim is, but I'm going to switch screens here for a minute. You're going to hear about the triple aim as you move forward with chems. And basically what the triple aim is they aim at three things. We want to make sure we improve the population health. We want to make sure that we improve the patient's experience of the care. And we want to reduce the cost of care. And so most healthcare facilities are focusing on this triple aim right now. They actually made a quadruple aim. The fourth thing is improving provider care or experience. So it's not just the patient, but also the provider. They want to make sure that we're all happy and we're all, you know, doing what we need to do to help serve each other's needs. All right. So once again, the big thing is reducing the cost, right? So we are, in theory, if we are able to prevent grandma from falling and breaking her hip, in the long run, we're reducing the cost of that healthcare for her, right? Because she's not falling and breaking her hip. She's not staying in the hospital for 2 or 3 weeks. She's not being in rehab for 6 months. And so the long-term effect of what we can do is huge. So we just need to capture that data so that we can go back to our insurance companies, go back to our providers and say, look, grandma was falling. She had fallen 3 times in a row. We went in, we did our falls assessment. We changed a few things within her home with her permission, obviously. And look, if she would have kept on that track, most people that fall and fall and fall end up breaking a hip and going to the hospital. But with her, we were able to stop it at number 3. And now she's hopefully will live a happier life. Financially sustainable. Obviously with anything, if you're not financially sustainable, you're not going to exist. And so, you know, how are we going to be financially sustainable within chems? We have to make sure that when we set up these programs that we have a payment method. One of the biggest faults that every community paramedic program that started with a grant has stated is that once people realize that there's a grant involved, then they think that that grant's just going to keep happening. And then those hospitals don't really feel like paying for their services. There was actually a hospital administration meeting where, you know, all these people from across the United States, these hospital administrators were talking about the triple aim and talking about sustaining healthcare and increasing healthcare costs. And one of the things they said was, don't pay for community paramedic programs. People are doing it for free. And that's bad, right? That's where we faulted. That's where we tripped up and screwed up in the beginning. We should have never done it for free. And so now you've got all these CEOs of these hospitals going out and saying, well, we don't need to pay for that. They're just going to do it. Free healthcare for us, right? Less money out of our pockets. So we need to make sure as you guys move forward with developing your program that from the start you have some sort of payment plan with that. Now, I know that like with Grangeville's system, they're a hospital-based system. And so the hospital is seeing this as an advantage because if they can staff an EMT, they're 24/7, which is something they've never had before. they can utilize them for chems, but also keep their ambulance staffed, right? And that EMT can leave that area potentially, or leave that appointment to go deal with the 911 call and then come back later to help Betty out. And so a hospital system like that, necessarily a payment isn't necessarily there in front of you, but it's payment in some sort, right? They're able to provide a better service. Legally compliant, obviously try to do everything legally. And really, I mean, I can't really go into all the legal stuff through this, but just make sure that you're certified, you know, your EMTs are certified. You're not out there doing blood draws on people on things that you can't legally do, okay? There are some waived laboratory tests that you can do, like a Chem 8. You can do, I think Coumadin levels are waived, but just make sure you're doing stuff legally. Don't go out there and say, hey, we can go do all this stuff for free, or not for free, but we can go do this as community EMTs and then find out later that you've been illegally doing stuff. So I think the laboratory thing is a big one. Yeah. All right. How exciting were the 11 steps? Yeah, very important. Not the most exciting stuff, but very important. So, all right, roles and responsibilities. The state definitely wanted us to kind of discuss what the roles and responsibility of a community EMT was. And so number one, we always have to follow our scope of practice. We can't deviate outside of our scope of practice. You know, I can't be taught how to do minor surgeries in the home and go do that, right? Just not within my scope of practice. So we need to make sure that we're doing that. So a lot of companies define it as an expanded role or an expanded scope, but once again, that must be following the state rules for your state. And then you always must work under medical direction or protocols. You just can't go out and dilly it yourself. In the state of Idaho, they also put a rule in that in order to provide chems, you have to be a service that provides 911. I don't know if I necessarily agree with that, because I think the private industry could be a good utilization for this. But I think they did it to kind of keep the money within the 911 systems that are struggling. So I kind of get both sides, right? But as different states might have different rules, and so there's a lot of private agencies out there that are looking into doing chems within their state. But in the state of Idaho, you have to be a 911 or 911 agency. The actual definition, we'll just go through it real quick. Community health EMS or community health EMS, whatever, means the evaluation, advice, or treatment of an eligible recipient outside of a hospital setting, which is specifically requested for the purpose of preventing or improving a particular medical condition, and which is provided by a licensed EMS provider or agency. Community health involving or related to emergency response must be provided in coordination with the primary 911 response agency for that area. So there was that little key factor about the 911 area. Community EMT, community advanced EMT is kind of a new role for Idaho. The community paramedic is also a new role for Idaho. And so when you think about as an EMT, what are some of the roles that you guys could do? Assisting community paramedics could be one necessary role. Health prevention programs could be another one. And then providing chems in the rural areas. I know with Payette, we had paramedics overseeing the program with EMTs that were assisting them. So if it was a patient that was not a high acuity, we could send our EMT to go take care of that patient versus like some of our CHF patients, we made sure the paramedics were there because we could do IVs, we could do Lasix, we could do EKG monitoring in the home versus some of the EMTs couldn't. So being able to utilize both levels will help save money within your program because you don't necessarily need to always waste your highest provider for something that, a provider that's maybe a little cheaper could perform. All right, so this is going to be a discussion page. So I'll have you guys unmute yourselves in just a minute, but we need to think about what kind of relationships can we build within our community. And so, I think one of them that's the highest priority is probably the hospitals. And, your district health office, right? Your hospitals are going to be the end all of where patients go, and they're going to be discharging patients and hopefully discharging them with you in mind. So if a hospital discharges a CHF patient, they're going to be trying to tie in your community paramedicine program to follow that patient for at least 30 days to keep them out of the hospital so they don't get readmitted, right? District health offices, kind of the same thing. They're following, the trends of diseases. And so like with COVID-19, could community health be a positive thing for COVID-19? Could we have, created some partnership with the health district to be able to provide free testing? Or, could we be going into facilities or nursing homes and testing our patients there when they weren't able to get some of that stuff out there? And so as this has progressed, obviously that stuff is now there. But in the beginning, could we have been a better help to the community or to the health district departments? And so I want you guys to just unmute yourselves and kind of think of some different partnerships that you can make and how that would help a CHEMS program. Stephen, if you're talking, I can't hear you. I think I see your lips moving.
Thinking out loud.
All right. Well, let's start with this. How many of you guys can think of some community programs that are around your area that might be beneficial to your patients? I know I've mentioned a few, so you can even recourse on some of those that I've already said, but what are some community programs that are out there?
But the only one that comes to my mind is just the home health nurses that are out there working with patients that don't have the access to get into their doctors.
Awesome. So yeah, we need to build a strong relationship with home health and hospice because you're going to probably be referring some patients over to them, and also assisting them at times. How many times have somebody start to die or something happens to a hospice patient, who are the first people they call? They don't call a hospice company, they call us, right? And so, I think that comes back to the education and partnership. Is if we know, one, what to look for the hospice patients, maybe we can prevent that transport to the hospital, because once we transport a hospice patient, they're kicked out of hospice. And so if they had a ground level fall, what justifies them going to the hospital that doesn't kick them off a hospice? And I think on the second side of that, what are the requirements, or the, I guess the requirements is the best word to say. What are the requirements in order for somebody to be on hospice and home health? Do we really know? I can tell you that I didn't know until we had a hospice company come and talk to us. And they said, this is how, and they had a checklist that we could take into the home. And if we felt like it was somebody that could qualify for hospice, we'd go through and fill it out. And then you know what we did? If they qualified, we called that hospice company and said, hey, do you want this patient? So see how that relationship can go very well. I know when community paramedicine started, home health and hospice were scared. They thought we were going to take over their jobs. And so they fought against us. We tried to tell them, we don't want that. We don't want that at all. That's your job. We just want to help get people onto your programs. And so as community paramedicine has evolved, they've been a little bit more lax on it, but the nursing board was actually involved trying to stop us from starting this. I don't know if you guys all knew that, but Adam, you look like you unmuted. If you got something there.
Yeah, can you hear me okay?
Absolutely.
Okay. Well, I've just been listening to just knowing that we can get in touch with like the Meals on Wheels and programs like that to help your patients, because I've been on several patients where you feel helpless and it's like, well, what do we do for them? So I think that's a big one. My question though, for the home health and hospice, I thought the only reason they would get taken off of it is if let's say they have lung cancer and they're having breathing trouble, if you transported them for that, then they would lose their status. But if they just, let's say they fell and broke their hip, you could still transport them and treat them for that, and it wouldn't affect their status. Is that correct, or do you know?
Yeah, Adam, you are correct. As long as their problem is not associated to their chronic condition, right? So you're
Right,
correct.
okay.
If they fall and break a hip, they don't want people to be in pain, and so that would be a
Right.
good justification for the transport. But that's where connecting that loop and talking to the hospice group before you transport is highly important.
Sure.
I know we go out on facilities all the time that someone has a ground level fall, and it's the facilities uh, it's the facility's rules or regulations that that patient has to go get a head CT, but they're on hospice.
Right.
So that would instantly kick them out, right? Because
Right.
that's not really related to their hospice necessarily, but it's
Sure.
also enough to where it could potentially kick them off. And so having that open communication is very important because it's kind of an unnecessary procedure, right? If they're not on Coumadin
Right.
and they're not having any signs of a head bleed, then really hospice can handle that there and they don't have to go get a CT. So it's kind of funny how like a facility will say this is our policy, but then home health is like, no, we'd have to kick them off. So it's always a
Right.
constant fight. So that's
Right.
good to have that education. And Meals on Wheels, you guys, it's funny how after you take this course, you're going to see the way you treat people is going to be totally different. I don't know if you guys go through people's refrigerators now, but when I go out on calls, probably about 75% of them, I'm going through their refrigerator to figure out, do they have enough food? Are they taking care of themselves correctly? Especially some of those diabetics, right? We're going out on a diabetic frequently and their blood sugars are always high. Well, how come? What kind of meals are they eating? And a lot of them are just eating Meals on Wheels and they don't realize this is a program that I'll give away to you guys, but they don't realize that they can actually, with Medicaid now, you can order food online and have it delivered to your house. Kind of like frozen food type thing, but it's dependent on their diet. So they can do a cardiac diet, they can do a diabetic diet meal plan, and instead of just depending on some lady who makes up a bunch of goulash and drops it off at their front door, right? And so that's a program that's out there that's been pretty cool to see evolve. And I think it comes out of a company out of over in Idaho Falls that actually sends it all out throughout Idaho, and it comes in a frozen or one of those freezer boxes, so it stays cool. It's pretty cool. Any other programs that you guys can think of, or anybody else that you should probably have relationships as community partners?
My concern is some of those programs are kind of obvious and they're available to us and we've known about them. It's the ones like we go through a spell of going on to homeless people. And I work night shift, which really limits our resources to help those. So we we do a huddle at the beginning and end of shift and we pass it on during the day. Hey, we went on this homeless guy for, the 12th time last 2 weeks. And when it gets cold, you go on them more frequently. So I'm more eager to find out what resources our community has for those, the indigent that, passing through town, got dropped off at the bus stop. One way.
Yeah, and you're exactly right. But what if we could even take it one step farther? And what if we could create a program for that homeless person? So they're calling you more because it's cold outside, right?
Mhm.
So how many nursing homes out there have old ladies that love to knit or create blankets for people? Is that somewhere where you can create that gap where old ladies are at the nursing home making the blankets for them, and then you're distributing to those homeless patients when you see them? And so that may be a way that you can actually solve that gap and giving people stuff to do. So I think
Yeah.
that's really cool. And then
Yeah.
also the food wise, the homeless a lot of times want food, and so is there a Meals on Wheels program that's willing to deliver wherever they're staying? So you could say, hey, if you're here every day at noon, your Meals on Wheels driver will drop you off food, and that may be a way to solve some of that too. You're not going to solve their homeless problem, and that's probably some of the hardest things out there, guys, is you'll start dealing with some of these guys and you just are like, why don't they want help? There's some people that just, that's their lives, they live that way, but maybe we can help them in just little ways. We may not be able to solve the home issue, but we may be able to solve the cold and the wanting food and utilizing the ER. So
Medication as well, their big concern is they were given that one-way ticket and with no medication. And so they're like, I take all these meds, psych meds usually, and we don't have access to them. So it's like make them not necessarily settle in the community, but in a right state of mind to maybe move on and access family or reach out to who they need to. So
Yeah, and down here in the valley, and it's slowly starting to move up into other areas. We have what's called crisis centers. And so if somebody's in a crisis and it's supposed to be a temporary crisis, but homeless would be a crisis, right? Or if they're having a psychological break, or they're just intoxicated and they made like dumb statements like I don't want to live anymore, but they don't really have a means or a drive to do that, right? They'll admit people into the crisis units, and these crisis units have, excuse me, sorry, medical personnel on scene. They have a licensed clinician on scene, and then they have security, obviously. And so the cool thing about this is the medical personnel kind of oversee that why they stay in these facilities, that they're not having any medical problems. They help them control their meds, and so they'll make sure that they're taking them on time, make sure they're not overtaking medications or abusing them. And then now they have an opportunity to sit down with a clinician, find some of those resources, and then be sent out to those additional resources. So here's the pamphlet for, some places where you can get a home. Crisis centers are kind of interesting. And the reason I know so much is because Victory, we actually partner with one of the crisis centers here, and we provide their medical care. So we have EMTs on staff 24/7 at one of the crisis centers. And what's interesting about a crisis center is they can't admit people. So they have to discharge people every 23 hours and 59 minutes. But then they can be readmitted back into the facility. They just can't technically stay longer than 24 hours, because at that point they now become a hospital and they're regulated a lot more. And so it's kind of interesting how they do that. But we've had clients there that, it's taken them 2 or 3 months in order to find the right resources for them. And we try not to make it into a homeless shelter, but some days it feels like that, especially with COVID happening. A lot of our homeless shelters are getting shut down. And so now these people don't have anywhere to go. So now they're going to the crisis center, staying there for a while, and then as they find resources, they're following their way out. So good. All right.
And those are actually managed really differently across the state, to be honest. One thing that we've been really careful in Moscow not to turn ours into a homeless shelter. And that one, there's a couple of them in the Boise Valley, or as far as I'm concerned, are pretty much running homeless shelters. And that's not what the funding was actually allocated for. But like you say, it's a great resource to get people connected to services and things like that. And so it really depends from center to center how they're handling that.
Yeah, and it's really unfortunate they can't condense that all so it all makes sense, so that it's the same everywhere you go, right? Because it would make our lives a little bit easier. Like this is definitely how these resources are, and from
the rules are consistent. It's just how they're being implemented across the state and are very inconsistent.
Yeah.
Sure.
And I know that COVID kind of messed everything up for everybody. So as we all know, I hate saying that word, but it's the reality of life now. Good. All right. Anything else anybody else wants to bring up, or are you guys ready to move on? Cool. All right. So that is module 1A. We do have module 1B. I think what we'll do is we'll take 5 minutes, let you guys grab something to drink, go to the restroom, grab something to nibble on if you want. And we'll meet back at about, let's just do 7:37, because that sounds like a fun time. That gives us 7 minutes. Sorry, I'm an hour ahead of everybody else too. So when I say 7:37, it's probably 6:37 for all of you. So don't come back in an hour. Come back in about 7 minutes. Thanks, guys. All right. Welcome back, everybody. You can still see my screen. This is Module 1B Insurance, correct? Awesome. All right. So I think kind of the importance of moving forward in EMS is knowing kind of how we get reimbursed and why there's a struggle on getting reimbursed with chems. And so we'll kind of cover some stuff that you guys may or may not know. I know in my years of EMS, I really didn't 100% understand how we got reimbursed. And so I definitely think it's important to go over and kind of how you can help explain to your patients too, kind of how things work. So insurance and the effects of EMS. So the US spends about 2.5 times the average just on healthcare alone. If you actually look at all these different countries, and I know it's kind of hard to see, it's a little small, but the United States pays a ton more than everybody else per capita. Finland, Spain, about half of what we do. Turkey, they're doing things right. They're not paying anything for healthcare. So, that's a major concern. Why are we spending so much money on healthcare alone? All right. So the cause of high healthcare in the United States, a lot of people base this on the fact that it's a quantity-based system. So you provide a service, you get paid. So the more services you provide, the more money you make. So why wouldn't a physician or EMS providers or everybody else just say, yeah, you need this? Do they really need it sometimes? Probably not. And we kind of talked about that earlier with, we go out on somebody with toe pain and we can't tell people, no, you can't go to the hospital, you can't go to the ER. We have to transport them, right? Those are kind of the rules and the regs of what the state put on us. But is that correct? Is it right to take somebody with toe pain right to the ER? No, it's an overutilization of that ER and not an appropriate place. But why wouldn't we take them there? We get paid X amount of dollars for taking them there, and that's the only way we're getting paid. If we tell the patient, no, stay home, we don't get paid for that. We don't get crap. So it doesn't really make sense. So you can see how if you tell somebody that, hey, the more you do, the more sprockets, more things that you create, the more money you'll make. I don't know where I was going with that word. I'm sorry, guys. It just isn't going to work for me tonight. So we're rewarded financially for doing more work. And as we all know, if you pay somebody $20 to do something for you, they're going to continue to do it to get that money. Also in the United States, we created this need for immediate treatment and care, right? We don't want care tomorrow. We don't want care next week. We want care today. So if I have a cough, I'm going to go see a doctor today and I'm going to go get that treated today. I don't have time, and it's the way the world has kind of moved forward everywhere. We don't have time to sit around and wait for stuff. We want stuff now. When the new iPhone comes out, we've got to have that new iPhone. We can't wait. Our iPhone works just fine, but now they have an iPhone that's blue. So that's definitely, I want that one right now. We've created this world of immediate need and want, right? And then the physician shortage just caused healthcare to rise. If we were able to have more physicians available, that gives people more options, our ability to get into the physician's office would be easier and our costs would eventually come down. All right. So, how can we help reduce this? If we had a revenue structure similar to other healthcare, it might make some more sense. Right now, healthcare is moving into where if you can prevent people from overutilizing, you get paid more money, right? So if you manage people better, you'll make more money than the person that doesn't manage people very well. And that's where those fines and fees started coming in with CHF patients, right? So the hospital said, hey, if you are able to keep all your congestive heart patients out of the hospital, none of them get readmitted. Not only will you not get fined, but we'll pay you a little bit extra to do that. And so physicians, they're seeing this as, hey, this is an opportunity for us to make money. And it should be the same for EMS. We should be able to get paid to prevent people from going and overutilizing the ER. Should we get paid to take somebody into the minor care? I think we should. If somebody has a small laceration that needs 10 stitches, why do we need to send them to a place that's going to charge them $3,000 when we can send them to a place that'll charge $70? And so if we are able to provide those services, it's going to reduce the overall healthcare cost. So how ambulance services are actually provided is we're viewed as kind of a delivery service. So we get kind of a flat fee for what we do. So you get an ALS or a BLS call or charge, and then you get mileage. So it depends on what you do on that call, but then there's a certain breaking point too. So if you went on a cardiac arrest patient, that's an ALS2 charge is what they call it. You could be using multiple medications, using multiple items to treat people, but yet they're paying you one flat fee for all that, right? We should be getting paid for everything that we're utilizing and using on that call like the hospitals do, but we don't. And so that's the big struggle for EMS is we keep getting more and more expensive stuff to be able to provide these services, but we're not getting paid any better to do it. So kind of your billing services available to EMS right now. These are the different base rates that you can provide. So there's BLS non-emergent transport. There's BLS emergency transport. So basically non-emergent means that it was pre-scheduled. Somebody called and scheduled an appointment on a Tuesday to take grandma who's completely confined to a wound clinic to get some clinic stuff done and then sent back home. That's your non-emergent transport. Dialysis patients would follow underneath this. You know, a patient that's on dialysis is completely bedbound. Your BLS emergent, that's where you were requested emergently to the scene. So if somebody called 911 and said, please show up, my mom has fallen, she's hurt herself, but you only provide BLS care. So you didn't give any medications, you didn't start an IV, then that would be a BLS emergent. ALS1 is basically you start an IV and you put an EKG monitor on them and maybe provided one medication, right? And so they have two different levels of that. They have the non-emergent transport, which be in my world would be somebody who's on a ventilator, right? So they're going from a skilled nursing facility to a doctor's appointment, but they're on a ventilator and they need somebody to be with that patient to provide that care. It's scheduled out. We knew it was going to happen a week ago. That would be your ALS1 non-emergent. Your ALS1 emergent would be, once again, where you provide EKG, EKG, 12 lead, IV, and maybe one medication, and then you transported emergently back to the hospital. So a 911 type scenario. ALS2 would be those situations where maybe you provided more care than what the ALS1 was. And some of that is like if you intubate somebody, they automatically become ALS2. If you've given 3 medications via IV, that's considered ALS2. If you did a chest tube or needle decompression, that's considered ALS2. And so, and defib and pacing would be an ALS2. And then your specialty care transport is anything beyond the normal paramedic scope of practice. So in the state of Idaho, if you run a IV pump of a special medication, let's say like potassium, on a transfer to the hospital between hospitals, you can actually charge specialty care because it's outside of a paramedic scope of practice in Idaho, but it's still an optional module that you can train to be able to provide. Is that clear as mud? Okay, so just to clarify that one more time, there's certain things that we can get trained on that are outside of the normal paramedic scope of practice that's legal within the state. So IV pump medications is one of them. And so with that, you can charge that specialty care rate. Another thing would be if you have a critical care transport team, they may be able to do some specialty care transports and be able to provide that. So all those 6 are basically your 6 base rates. And so you have a certain amount set to those on each agency. So let's just use Victory, for instance. Our non-emergent BLS rate, I believe, is $420, okay? So just loading that patient into our ambulance, that's $420. And then on top of that, we get to add the ground mileage. And those are statute miles. If you guys are going by Google Map miles, I'm telling you, you're losing money, because what Medicare says is that if you have to divert because of construction, or that you had to go around a car wreck, or you decided this was a quicker route, may not be the shortest route, but a quicker route, they'll still pay you for that extra mileage. So it should be very important that you guys are keeping track of your actual odometer readings, not just going after the call and Google mapping it. Because we, even here at Victory, have found that, we had a transfer to Utah, and they ended up being stuck by a car wreck that had the traffic shut down for a couple of hours. And so they decided to go around the car wreck. It added like 60 miles to the trip. That's 300 and some bucks. That's one of our personnel's cost right there that we were able to save because we actually did the odometer reading versus what Google told us to do. So each one of these are a base rate. The crappy part is even though we're charging $420 for a base rate, Medicare may only pay 250 of that. Okay, so then we get paid from Medicare, and then patient's responsible for the rest of that. Well, with Medicaid, let's say we do a BLS and we charge Medicaid $420 for that base rate. Medicaid says, hey, we're only going to pay $189 for that trip. The difference between Medicaid is that's all you get. You cannot go after the patient for additional money. And so you can see how, you know, if we transport a lot of Medicaid patients, it's definitely a huge burden on an ambulance company, right? Because you really want those people with insurance because that's who's going to pay your full rates. So we kind of have to play that same game that the hospitals pay. All right, future of healthcare. We cannot continue to do the same thing over and over again and expect a different outcome. Right now, we continue to do the same thing in EMS. We continue to get paid the same rates, but our requirements are higher. Our skills are going up more. We have to supply more expensive equipment, and we're being expected to do more stuff. And yet we're not getting reimbursed the same. So if we continue to do what we're doing now, EMS won't survive in 20 years. We need to make a change. So with that, healthcare decided to develop the triple aim. We talked about that. It's kind of a guide to help drive people to make that change. And so like we talked about, we want to increase, you know, the patient's outcomes. We want to decrease the cost. We want to make sure that their experience is better. We kind of touched bundle payments, but we'll talk about that again. If you provide a good patient-centered home, patient-centered care, if you're able to reduce the amount of times the patient goes into the ER or the overutilization, then those insurance companies will actually pay you a bundle payment for what you did. So they may say to a physician's office, hey, if you keep your diabetics, you know, from going into the hospital, let's say you have a 10% admission into the hospital, that's a pretty good amount. We'll pay you additional money to keep that at 10%. If it goes above that, we're not going to pay you that bundled rate. CMS bonus and penalties we've already covered. Satisfaction-based payments, that's just using you know, that customer experience as a way to pay people. And so if you have high ratings with your customers, some of these insurance companies are giving you a bonus for that. And then ACO and IDS, I honestly can't remember what the heck those mean. I'd have to relook at them. It's been about a year since I made this, so we'll just ignore that for now, and I'll follow up with that and figure out what those are. Triple aim, we've already talked about that. We'll skip through that. So looking at these and the cost of these, and we kind of already touched this, but I want somebody to kind of think about it and answer it. How could insurance companies save on these costs here? How could insurance companies reduce paying ambulance services more money?
First thing that comes to my mind is only paying it once, like repeated transport, similar to repeated hospitalizations.
Yeah, and that would suck if the hospitals decided to do that to us, right? But it is a possibility that they could do. They could say the same thing to us as they say to the hospitals. So that would suck. Anything else?
I guess one thing I was thinking is that, I mean, if you're providing a service that allows people access to better care or just care in general, so you're providing a BLS provider that's taking care of some of these needs that they're not getting met, which reduces the chance that the ALS service is going to have to come out and intubate them or whatever, you know, in the long run, it's better care of the patient, which equals less money spent on them potentially.
Awesome. Yeah. So our prime example that we talked about earlier is sending a BLS provider out there to do a falls assessment of the home, and in theory would reduce the chance of maybe an ALS provider having to go in there after she breaks her hip and happen to give them pain medicine, putting the the splint on it, maybe the hip splint. Maybe even to the point where they've fallen and hit their head and caused a subdural bleed, and now you have to intubate them. So you're 100% right. Being able to do some of that preventative stuff in the beginning could reduce the amount of money that they pay. Talking about, I've mentioned it before, ET3, and one of the things that they have hinted around with that is paying ambulance services their rates. So they're still paying us the same rates to take people to the minor cares, or to take people to an alcohol withdrawal treatment center, or to transport people to a mental health facility. Because how much money is that going to save them? They're still paying the ambulance rate, but they're not paying the ER visit, right? They're not paying then for the transport from the ER to that facility. They're not paying all these additional costs that are associated with that. If we could bypass the middleman completely, how much money would that save the insurance companies? Tons. So that's one of the focuses of ET3, and I know they kind of put it on a hold due to COVID, but it's still in line to be started and initiated. And that's one of their concepts, is what if we can do that? Another concept they're doing with ET3 is talking about telemedicine. What if we show up on scene, we get them set up with a Zoom conference like this with a doctor. Doctor goes, "What are your symptoms?" And they're like, "Oh, I have frequent urination, and I have burning urination, and it's very foul smelling." And they go, "Great." Not great, but hey, it's easy to solve, right? Let's write you a script. We'll send it to Walgreens. Bam, they don't even have to leave their house. And they're going to pay us our regular BLS fee to do that, because now they've reduced everything, right? They've bypassed everything. And then they give the physician a little bit of money, like $100 a visit to do that, so that could benefit both the EMS and the physician. And so that's a big thing that ET3 is focused on. All right, talking about the bundle payments just a little bit more. Model, and these are different models that different insurance companies are doing out there. Model 1 is just inpatient stay for acute care hospital. Model 2 is inpatient stay in acute care hospital, all related services during the episode. Model 3 is paying to trigger by an acute care hospital stay beginning at the initiation of acute care. So the 30, 60, 90 days that we were talking about. And then Model 4 would be CMS would make one payment to the hospital, and the hospital would determine who gets paid. Model 4 scares me a lot. And kind of just to explain what that means is that Medicare may say, okay, we're going to pay, let's say you transport a patient to St. Joe's up in Lewiston, right? And so the hospital says, okay, we're going to pay St. Joe's $100,000 for that patient that they just transported, right? Now St. Joe's gets to decide who all gets that money. So they may say, okay, the ICU used up 80,000 of that. We had to put them on a therapist for 20,000 of that. And now we don't have any money to pay our ambulance to just deliver that patient. So that's a scary concept and a scary model for me to think of, because I guarantee you that if we don't become more involved in healthcare, we're going to be the last ones that are going to want to pay. They'll pay us in snacks when we drop off the patients, right? That's how they get us to do it now, snack rooms. So the bundle payment for the inpatient stay in acute care hospitals and all services during that event, that just means that they pay one flat fee while they're in that acute care hospital. They don't care how much stuff they do. They don't care if they use up all that money. They don't care if they save a bunch of that money, just as long as that patient leaves that hospital and is healthier. So it's up to the hospital how much services they put into that patient. Performance-based models, these are a little bit better, but once again, it has to do with a lot of data. So, giving people bonuses if they have better satisfaction on patient experience. And so now we'd have to create surveys for our patients, and then they decide whether or not they're going to pay us a bonus for that. Some hospitals have actually created a position just to make sure that people have a higher satisfaction. I can't remember what the CXO actually means. I think it's like chief experience officer, maybe. I can't remember what that title was. But if you guys, I don't know how many people have traveled down here into the Boise Valley for a while, but we have a bunch of hospitals and freestanding ERs that have kind of developed. My prime example is when St. Al's Garrity set up that freestanding ER. The first thing you saw when you walked in was a coffee shop and like a little place where you can get sandwiches, right? And then as you continue to walk through the hospital, then you got to actually get to the ER. Then you got to do, some other things. They're also starting to create these hospitals in high frequent areas of flow. And so they're starting to put them by shopping centers, by places that are very busy instead of out in the middle of nowhere. And so these hospitals are planning this because who wouldn't want to go to Walmart, get their prescriptions or their food, and then go visit the ER for a couple hours? And as long as you're happy, and you got your Starbucks coffee, that's the way to go. And so as you continue to move around into bigger cities, start looking at the hospitals and how they're building them less like hospitals and more like these very customer happy areas. I mean, I think St. Luke's Nampa has a little garden that you can go out and meditate, because once again, maybe the patient will be happier if they go out and meditate. Maybe they need to build a golfing green out there. That would be nice, right? Go golfing. So, specialty dining is another one. They're associating them with, these fine dining areas. And so I know one of the things that our patients always tell us is like, oh, thank goodness we're going to St. Luke's this time. They have the best food ever. They're selling them. They're selling their business. It's kind of evil. But of course, they see the advantage of that because they'll get paid more money. ACOs, hey, this is what we were talking about earlier that I couldn't remember what it was. So an ACO is just accountable care organizations. These are a group of healthcare providers that work together to come up with a solution for the patient. They try to prevent duplication of services, and their costs are kind of just split between everybody. And so you might have somebody that's kind of watching the making sure they're being financially responsible with that patient, making sure they have somebody that's watching their data and making sure that it's not infiltrated, or that we're being HIPAA compliant. Another person that's watching the liability of the care of that patient. Here's another thing that's just kind of scary is integrated delivery systems. And so more and more healthcare providers or insurance companies are buying out big companies' healthcare systems. And this is scary because insurance companies are now controlling the cost of our healthcare. And so there was a big, I believe there's a big healthcare system that actually bought Walgreens and Rite Aid, and they're controlling some of the cost to the medications. And that's the insurance company that's controlling that. So that's kind of scary. And so as these insurance companies get bigger and bigger, they're starting to buy out more and more of the healthcare. And as you'll find, they'll probably start buying physicians' offices. They'll start buying, different plans. The big one down here that I can think of is Select Health with St. Luke's. So your healthcare system, your insurance company is also your hospital. And if you don't use their hospital, you pay a lot more money for care. And it's kind of scary. And if you ask anybody, they all hate Select Health, so don't ever get it. If anybody works for St. Luke's, I didn't say that.
Most of us work for Cadre, which is Intermountain.
Good. But you'll see that all over the nation. There will be healthcare facilities buying each other out. Kaiser Permanente is huge, right? You guys have all heard that name, and you may not know how much stuff they actually own. If you actually Google it and see what they're purchasing and what they're owning, it's kind of scary. And they're going to start driving those prices up because, yeah, you're going to be paying a lot for your insurance, and now you're going to be paying a lot for your healthcare. And guess what? They're making money no matter what you do. So. CMS bonus and penalties, kind of touch base on this a little bit. This is once again that value based kind of on readmission rates. So if you have a low readmission rate, we'll pay you a bonus. If you have a high readmission rate, we're going to fine you. These are basically based on 30-day readmissions, but they're starting to push those off to 45 and 90 days. So you can imagine that if you have a pretty sick CHF or COPD, or a COPD is another one that gets readmitted quite frequently. It's kind of scary that you got to make sure they stay out of the hospital for 90 days or else your hospital system won't get paid for it. And I don't want them to push that off on EMS like we mentioned before. What if they say, hey, we're not going to pay you for a transport anymore because this guy's already utilized us once before? So that's scary. Estimated $12 billion just spent on readmissions per year. So that's going to be your good selling point to your hospitals, is our KEMS program is designed to reduce readmissions. They're going to love hearing that. Now you just got to stand behind it and prove it. Okay. So with PAET, we actually were kind of lucky. We focused a lot on congestive heart failure. We were able to prove that being able to provide KEMS within that program help reduce potential readmissions. We have to always call it readmit potential because we really don't know if they'd be readmitted or not. But kind of the story that I have on this is we had a guy, and kind of the nice part about PAET is we didn't have boundaries, so we moved into other counties, which was kind of nice. We saw a guy in Weiser, and he was a very bad CHFer. When I went and first saw him, he could barely walk from the car to the house to sit down and talk to me for our meeting. That's how bad his CHF was. He was on oxygen. The doctors were telling him, hey, you need to get on dialysis or else you're going to die. And the first day I met him, he sat down and talked to me, and he's like, I'm done. I just don't want to fight anymore. And so did some education with him on dialysis, how the process worked, how he could survive for years and years to come if he did dialysis, and just kind of let him kind of stew on that for a while. And then the next visit that I had with him, I kind of sat down with him. I said, what are your big concerns right now? And he said, well, one of them is financially. I just can't afford to continue to go to the hospital. I can't afford dialysis. I live in a trailer. And so he was a good example where we started moving on that Medicaid right away. And so we were able to get him on Medicaid. He was also telling me financially that he would lose money about halfway through the month. So he'd be completely broke halfway through the month and then couldn't afford to eat. And so that was one of his other concerns, is he's got to kind of store food, which I don't know how, if you're storing food, how you continue to gain weight, but magically people do. But he was unable to afford food after about the 15th of the month. So we hooked him up with Medicaid, which helped reduce his cost for healthcare. Number two, it helped him with dialysis, being able to afford dialysis. We were able to get him on he wasn't eligible for Meals on Wheels, but he was eligible for the Medicaid delivery of food. And then that was also positive because he had that cardiac diet that he could follow. And I can tell you, within a month and a half, I've never seen somebody so happy in my life. He thanked me, and feels good to have that feeling, right? It's not every time that you have a success story. But he said, you changed my life completely around. He said, I was ready to quit. I didn't want to live anymore. And you've completely changed everything and helped me out. And so we were able to take that case, just that one case, and go back to St. Luke's and say, hey, this is where this guy potentially would have been readmitted multiple times, because he would have just kept using the ER whenever he couldn't breathe anymore. And now he's using the dialysis. He's no longer going to the ER. He's able to sustain his own healthcare. And that was huge. So they ended up giving us a small grant to be able to afford our next year of our KEMS program. So that was kind of cool, just from that particular incident. Penalty right now, the max potential penalty is 3%. I think that if that is not enough to push hospitals to reduce the readmission rates, that they're probably going to up that. And so CMS has the power of doing that. And I think hospitals are scared of that. So kind of explain the 3%. If a hospital collects over $100 million in Medicare funding and they get penalized for that 3%, the hospital just lost about $1.5 million in revenue. That's a huge amount of money. The other thing is hospitals are also publicly shown in the public's eye for getting the fine. So you can log into the CMS website and you can actually see what people's readmission rates are. And so a lot of hospitals don't want that bad negative view on their hospital. And so they're going to push hard to make sure those readmission rates are low. And then that way they can say, hey, we're the #1 provider of congestive heart failure care within our community. And they can use that to help advertise their hospital also. Definitely don't want to get a bad name, because then, as we all know, down in the valley here, it's the St. Luke's versus St. Al's. So, St. Al's would probably use that against St. Luke's. Hey, look, St. Luke's is getting all these penalties and we're not. You should use our system. So definitely a war between hospitals sometimes. All right. A lot of different types of insurance out there. There's kind of the state funded Medicaid. As we all know, that's the lowest paying one. We've talked about that. Medicare is our next most popular. That's going to be anybody over the age of 65. Just remember that Medicare does not pay 100%, that your patients are still responsible for 20% of their health care. So I think that's something that's kind of misconstrued or misunderstood, is that, when I first started EMS, I'm like, oh, you have Medicare. That's cool. Come on, let's go. You're going to be paid for. Yeah, that's not true. It's a lot like private insurance. Private insurance, obviously, they have a lot of rules and regulations. If you go in network, you pay a certain amount. If you go out of network, you pay a certain amount. If you go out of network and we decide we don't want to pay for it, then you're responsible for the whole amount. And then we have supplemental insurances out there. Those are kind of a backup. So there's a lot of supplemental Medicare programs like Humana. If you guys have ever dealt with Humana, it's a nightmare. We actually had patients that couldn't go to a particular ER because they had a Humana. They were absolutely telling us not to go there. So it's just kind of interesting to see how some supplemental insurances will say, yes, you can do this, other ones say no. And so when dealing with your patients, you're going to learn a lot about healthcare insurance companies. And if you do manage an EMS group, you're going to learn a lot about them too, because you got to pre-auth stuff, you got to get acceptance. It's a lot of pain in the butts. Sitting on the phone for hours to get a $400 trip sometimes. So this is just the websites that you can get some resources for insurance questions. We're not going to go deep to detail about it, but some of the most popular ones in Idaho, obviously Idaho Medicaid's on the healthandwelfare.gov. Medicare.gov is a popular place. You guys can frequent that. There's a lot of good information there. Blue Cross Idaho is pretty popular, and then Select Health is another big one. So back to kind of how this is going to affect EMS. There's a big push to reduce inappropriate utilization of EMS services, and we talked about that earlier, where insurance companies are actually rejecting payment for their patients if they don't feel like their utilization of the EMS or the ER was appropriate. Reimbursement is always changing. Every 5 to 10 years, you'll see a huge change in how they want to reimburse people. And so we've been kind of lucky in EMS that we've kind of stayed with that base rate and that mileage, but at the same time, we're unlucky because I think there's so much more that we can bill out for and get paid for. So it's kind of a win on one side, a loss on the other. CMS is looking highly into ambulance billing fraud. They love to pay people to report fraud. And so if you report fraud, I think you get an X amount of dollars just for if it's confirmed. They had an ambulance company in the South that was transporting dialysis patients in the front seat of the ambulance and charging BLS rates for that. That ended up being like, I want to say like $3 to $4 million in just inappropriate funds that had to be paid back to Medicare. So we definitely have to be careful on what we're doing with anything that we do for transports. And then obviously we talked about ET3. There's new emerging models for payment in healthcare. All right. Was that not so much excitement? Yeah. But now you understand how you get paid, right? It's always important. Why your bosses are always like, guys, stop getting refusals. Get people to actually go to the hospital. We really need the money. All right. right, we're gonna move forward to module 2, and we'll break partially through this, and then after module 2, we'll be done for the night. Okay, guys? So I'm gonna try to do 2 modules a night. And hopefully, like I said, these first couple modules are dry, and I'm really sorry. I'm trying to make it as entertaining as possible, but these are definitely things that we need to cover in order to talk about community health EMS. All right. Let's see here. This is loading content. All right. So I would highly suggest that if you guys are going to start a CHEMS program, that you guys do what's called a community needs assessment. This is where you're utilizing your resources in order to find out where the gaps are within your community. Like we kind of touched before, if you're not looking at the gaps and you're just kind of throwing a dart, trying to figure out what the problems are in your community, your CHEMS program will probably fail because there's probably already resources out for half of what you think that you need and you really don't. So talking about community needs assessment, there's different steps and parts of the community needs assessment. Number one, we need to conduct some research. And when we think about research, we need to make sure, and research and sources, we need to make sure that we're going after reliable sources. If you guys are going to be doing some research, it's probably not going to be very helpful to pull data from 1970, right? We probably need more newer data, new information. And then we need to find existing data that's already there too. We have some good sources of data. Our PERKS program is a great place to start, right? You could pull data on what are our highest calls, like what type of calls are our highest call volume. So is it diabetics? Is it chest pains? Is it COPDers? And that's kind of a good start, right? Start where we know where the data is, and then build onto that. So next step would be, what is the data that the hospitals have, and does it correlate with ours? So is the hospital reporting a high level of COPDers, and are we reporting a high level of COPDers? When we think about reliable sources, we got to think about CRAP. And this is a great acronym. Number one, currency. How new is the material that you're researching? Reliability and relevance. We've all been told, at least I was in school, at least college, I didn't have the internet when I was in high school, but in college we did, is that Wikipedia is probably not a good place to get your research data from, right? Wikipedia is something that people create. It's good information, but we probably need something like journals, news articles, stuff that has some validity to it. Authority and audience. What you got to think when you're reading your research, is it made to kind of skew the audience one direction, right? There may be somebody that's trying to prove a certain point, and so they're kind of skewing the data in their reports. So my prime example of this is, if anybody's ever trying to think of the documentary guy's name, Michael Moore, right? Has anybody seen a Michael Moore movie? I think his most popular one was about guns and how it's unsafe in America, and he has a very strong point that all these things we're doing are against having gun rights in the United States. But he doesn't really look at the other side. He doesn't really show you the data on the other side. It's very skewed one direction. Michael Moore is very notorious for that, the very liberal view, but not really opening up both sides and making you the option of making your own opinions from that data. So real good data doesn't try to skew your mind or your thought. Good data says, this is what we found, this is what we believe, and let you kind of decide what you want to believe from that data. And then purpose and point of view kind of follow in the same thing. You know, is there a purpose behind their data gathering? What was their point of view when they gathered it? And so I think a perfect example of this is kind of going back to COVID. How much different point of views have we had about COVID? You know, it's airborne, it's droplet, it's not anything. Masks help, masks don't help. What is their point of view and why are they saying that? And so just kind of use that as a reason to kind of sort through your data that you're getting. All right. Where to find existing data? Obviously, the internet is a great place to find whatever you guys need. There's Google Scholar. I believe it's called Google Scholar. Google has just a separate search engine just for research data stuff like journals, research articles, all that great stuff. Those would be great places to get that. GEMS magazine has a bunch of good stuff. So does what's the other one? EMS World magazine. Which one is that called? Anybody help me here? Yeah, EMS World magazine. See, I have it. Those are all really good resources to pull some of that data, especially when it comes to research in chems and community paramedicine. They have tons of articles. I believe it is, I'm going to jump out of this just for a second. I believe it's EMS World that actually has just a section on their website just on chems to help people with some of the data that's out there. And GEMS might too. They both have a lot of good information. All right, I'm gonna try to find this, but we're gonna keep talking as we go. Local needs assessments performed by the hospitals. Like I mentioned before, each hospital does a needs assessment every couple of years. And so you can usually pull that off the internet. If not, go to your local hospital and ask them if they've done a needs assessment. That's gonna save you a lot of footwork, right? Because they're gonna be focusing on the same stuff that you're gonna be focusing on. And so that would be a really good resource to use. And then your library, if anybody still has libraries that exist that you can get into, a library is always a good information source. A lot of libraries have gone digital now, so that would be a good place. And then, even universities keep a good level of data on hand so that their students can do proper research and learn. So they're always updating their stuff pretty well. All right. I went on the EMS World website and I couldn't find what I was looking for, so hopefully I can find it before the end of this talk for you guys. Some reliable websites that I like to use, Idaho Health Statistics. This is a pretty cool website. You can go on here and just see what the vital statistics are within your area. So what the birth rate is, what the marriage and divorce rate is, mortality rates, stuff like that. And so this has some really, really good information about each county and area within Idaho. Criminal data, if you have a high rate of assaults or alcohol use or stuff like that, you can kind of see that alcohol and gun issues are related to how much criminal activity is in the area. So that may be a good place for you to get stuff. Idaho website, idaho.gov website has a lot of good stuff. And then the census, this is another good place that I like to do to get information about our area. So if we were to explore data, let's see if I can find this easily. Let's go Moscow, Idaho. It's going to print up some pretty good information all about that city. Everything from the age of the population to how many people are insured in your area. And as you continue to build onto your program, it's also going to be able to tell you some stuff about everything from population to how many people are under 18, how many people are over 65. This would be a good number to see because you're going to assume that 9.5% of the people that you service are going to have Medicare, right? Talking about different origins, the housing, how much does it cost in your area for a house? In this town of Moscow, it costs $224,000 on average to buy a house. That's quite a bit more than it is in Caldwell for me. I wouldn't buy a house for that much in Caldwell, I can tell you that. Also telling you about, how many people have a computer in their house, how many people have internet. And so this is all kind of good information that you can use to triangulate. The other good one that I didn't have on the list, unless I have it on the next page, is county health rankings. And I use this one quite a bit when I do performance on areas, trying to decide if we want to move forward with EMS in certain areas. Definitely something you want to use to help decide if you want to do certain thing within community health. But let's say we want to do Cassia County, I believe that's one of them that's over there, right? It's here, somebody representing. It automatically went to Idaho, but this gives you some good information about, how many people smoke in Cassia County, how many people are obese, and these little red things are telling you these are high issues. So as you do your data collection, you may say, hey, I see we have a high issue with sexually transmitted diseases. Maybe that's something we can focus on as a community health program. Maybe we can hand out condoms to everybody. I'm not sure, but you guys can figure that all out. Steven's just laughing up there. I don't, he can't help it. And then the green ones are kind of the good spots. So Cassia County actually has a pretty good rate compared to the national rate of uninsured. So you only have a 16% uninsured rate. I use this data, like I said, to help decide whether or not we want to move EMS into a certain area. They're called performance. When I look into an area, so if I look at Cassia County, I'm going to expect that 16% of my call volume isn't going to pay their bills, right? So, and then in the other one with the Medicare, 9% of our population that we're going to transport is probably going to be Medicare rates. And so you can start using this data to kind of decide how much are we going to get paid for the services that we're doing in this particular area. Looks like you guys have a little bit of issue with flu vaccines. So is that something that your community paramedicine program could do? Could we provide flu vaccines? Could we help the health department get those just distributed out every year? Because we know that if we give more flu vaccines, less people are going to get sick. Less people get sick, less people go to the hospital. You can see how this all gets related to each other. Like I said, I love this website. I can spend hours talking about each one of these and how they affect community paramedicine. Air pollution. It's something you probably wouldn't think about, but if you got high air pollution, you're probably going to have more COPDers and asthma patients, right? Especially during those days that are high peaked days. So the fire days, the days that fires are seasons up, maybe the days where the inversion is there. So, in the Treasure Valley, you'll have an inversion and you'll have more COPDers. And those are the days as a community paramedicine, you train your patients that, hey, you're a pretty unstable COPDer. You should be kind of watching the air quality. They report it on the news every day and you watch it every day. If he says that it's a red day, you should probably stay inside and not go to the store. You should probably go to the store on a green day, and that'll help those COPDers stay out of the hospital. And so, once again, really good information on this county health rankings. Use it, use it, use it. I honestly, when I first started community paramedicine, I thought I'm never going to use that thing, and I use it all the time now. So, something I've learned in doing this. Here we go again with research articles, GEMS, NAEMT. That was the one I was thinking of that had all the good articles. Let's look at that one because that has amazing resources. So up here on NAEMT, they have different, so the initiatives right there, MIHCP, that right there has tons and tons of information on community paramedicine. You can click in here to their program toolkit. They've got stuff that's already been created that you guys don't have to recreate, okay? Heart zone failure tool. You guys want to start doing this? You can start handing these out to your patients. It's already built out. It's free for you guys to steal. Borrow, appropriate, however you want to say it, okay? These are really good tools to give your CHF patients to say, hey, if you're in this zone, this is when you need to, you're doing good. If you're in this zone, you should probably call your doctor. If you're in this zone, you should probably call 911. And they can put these up. As you go through some of these homes, you'll actually see the hospitals are handing these out to people. And if you explain this to them, they'll be able to go, hey, I'm in the yellow zone. I need to call my community health EMS provider, and I need to figure out, do I need to just increase my Lasix? Or, do I have something else going on that they need to look at? And so I gave my card out to every single one of my patients and said, hey, if you get in this yellow zone, call me and I'll come over and we'll figure out how we can prevent you from going to the hospital. Keep going through, you'll see, I think it's page 3. Here's some stuff from Ada County paramedics that they put on here, So it's not just national people, it's people here in Idaho that have created these. Ada County is in a lot of this. Sepsis care management, daily weight logs. And so these are all forms that, successful community paramedicine programs have already created. So why recreate the wheel? So NAEMT, good place. They also have some other initiatives, mental health, fitness. EMS 3.0, I think, is the new change in the healthcare system, talking about how, you know, kind of what we talked about with insurance and payments and stuff. So really, really good information. All right. Paper articles on chems. There's a lot of stuff out there, especially there's a couple of YouTube videos that I think I'm associated with. If anybody finds them, don't make fun of them. But we sat down and talked to one of the Boise news channels about what chems is and how it was being utilized in each different agency. And so we had us and Ada County, Cascade Rural Health, I think, was there, and then there was another group I can't think about. We were just talking about chems and how it affected our communities. So that might be some good areas where you guys can get some information. Local health departments have tons of research and data. They love to research, as Stephen will probably laugh again, but STDs is one of the things they track very well. And so, you know, if you're in Cassia County and you decided that was going to be something you guys focused on, the health department would be a great resource because they have tons of information on that. You know, also with COVID, if your focus was COVID, you know, they're going to have tons of information on COVID, probably more than you ever wanted, probably more than we ever wanted to hear about it. Local needs assessments, not just hospitals, but health districts also do these these needs assessments. If you have a university or a school next to you, a big school, they'll usually do these. So I know BSU has done them. I'm sure U of I have done them. And so those are people that went out and did all the research for you. You're just stealing and borrowing it. Okay. And then your local governments do a lot of research too. Libraries can't feed into that anymore. Libraries are boring. All right. So needs assessments. You know, we got to have a backbone to our program. It's going to help build confidence and relations with our stakeholders. And so if we're able to say, hey, we took all this data from this needs assessment and from this and this, and we triangulated and decided that, you know, we were going to focus on immunizations, it's going to mean a lot to that hospital that you did that. They're going to say, hey, these guys know their stuff. And yes, this is the same stuff that we came up with, that we identified as a problem. And so it's going to build confidence in your stakeholders to believe that what you're doing is actually working. Also, it's going to help you prioritize how you measure. So if you're going to focus on immunizations, you're probably going to measure how many people in 2018 went to the hospital for the flu. And then in 2019, we started our immunization project where we did the flu shot. And now this is the level, and it's actually come down. And we have less people calling in sick for, you know, their jobs. We have less people visiting the ER. Obviously, we've tracked this and proven that this works. And so, you know, that's going to help you kind of prioritize how you're going to keep track of your data. Wow, am I doing good on boring you guys yet? Somebody shook their head yes. That's awesome. Adam just left. He's like, this is so bad that I'm just going to leave. I'm surprised he didn't put like a cardboard person there just to pretend like he was paying attention. So
He got thrown out to go on a call.
I'm sure that was it. That's what they always say. I'm sure he probably had to go get dinner. And I see Bob's made it on. Hi, Bob. I have to switch pages to see you, but I'm going to expand it so I can see you now.
Hi, Travis. Yeah, I was on a call until about 6:30.
Yeah, I think Kim told me that, so I'm glad you're on. We are recording it, and I will put it on YouTube eventually for you guys to look at, so you're not
Perfect.
alone. So, all right. So moving forward, kind of talk about the steps to create a need assessment. So number one, we need to plan. We need to figure out a plan on how we're going to do it. Are we going to, you know, work together as a team? Is one person going to take it on? You know, how are we just going to focus on a certain thing that we feel like is an issue? So what you may do is go, all right, let's run our data first. And let's say COPD ended up being what we noticed a high rate of. So let's plan on doing our needs assessment based on that, right? And see if we're correct. Second, you have to conduct it. So you have to collect all that data. You have to triangulate it, make sure it makes sense. Next thing, we have to review it. We have to make sure that what we collected is accurate, that it's right, and it's real. Consolidate it into a plan, and then execute that plan of action. So let's just use COPD again. So we identified that's something we want to focus on. We conducted the research and realized that everybody is having that same problem. The hospital's having that problem. Our patients are expressing that concern that they're having a hard time with their COPD. Our ambulance service is transporting a lot of patients with that. You're going to review all that and then come up with your plan, right? Our plan is to visit these patients, educate them on good days to go outside, bad days to go outside, educate them on signs to show when they may be going into that yellow zone that we talked about. So maybe you have a little form that you educate your patients that in the yellow zone, when you start noticing shortness of breath with activity, that's a good time to get a hold of your physician and maybe get put on some prednisone before it becomes too bad, right? Maybe even given some neb treatments instead of just using a regular inhaler, and then initiating that plan. All right. Yeah, I kind of already covered all this. Assemble your team. Great hospitals, physicians, district health offices, social assistance agencies, first responders, anybody that you can think of that would be directly involved in that patient care, get them involved. Conduct it. We talked about that already. Confirm it, validate it. This is kind of fun. Data is really just numbers till organized. And what I tell my employees is that data in or data out is as good as the data in. So if we don't put the data in our charting, or if we don't submit that data, then the data that comes out is going to be not so good. I noticed some things that people get frustrated with is I'm like, hey, make sure you're documenting all the patient's medications on your EPCR. And they're like, why? Why can't we just say C list, right? Well, because if I want to pull data on how many people were using albuterol, that were COPDers, I would be able to do that if it's in there. But if you just put C list, it ain't gonna matter to me. It ain't gonna produce good data. So be on your group of people to make sure that from the start of your community paramedic program, that you guys are putting in good data, not just giving junk in there. Because you gotta, I can't express this enough, you gotta prove that this works or else people aren't gonna support it. And then just, share your assessment with your stakeholders, share your data with stakeholders. Hospitals love data, love it. It's actually kind of funny because we're talking about implementing some health data exchange with the hospitals so that we share information with them. They want our PCRs, they want our information, they want it integrated to their system so they can pull how quickly did the medic put on the 12 lead, and then how quickly did that patient go into the cath lab, right? The hospitals love that. They love to be able to prove that because then they can say, hey, look at us. We've got a quick in the cardiac cath time, and this is why you should use our hospital. But they don't like to share data back with us. That's frustrating. So that'll be a big hurdle you guys have to deal with. And one of the things that Image Trend is able to do, one of the things that ESO is able to do, and they're just trying to get the hospitals to agree with it, is give us feedback on what we transported and what the patient's diagnosis was. I think that'd be huge. If I went on a chest pain patient, I gave nitro and aspirin, and then I came back a week later and it gave me a report that, hey, dummy, that was a UTI, then maybe it'd make me think about what I'm doing, right? It makes me smarter, it makes me better at providing better patient care. And so I like to be able to get that feedback back. What happened to our patient once we drop them off? And it's going to be the same with your chems patients. You're going to want to know, if I referred them to the doctor, what did the doctor do? And how did he do it? And did that really prevent them from going back into the hospital? All right. Once again, we stress this, and you guys are going to hear me repeat a few things, and that's why it's so important. You'll hear me repeat it. Means it's probably important. We need to find a focus for our chems courses. It'll build confidence. It'll sometimes identify issues you didn't even know you had, but it'll also identify issues you thought you had that you really don't have. And so, when I work as a medic out at Payette, some of the stuff I deal with is homeless people. But when I actually ran the data and actually looked at it, we really didn't have that big of a homeless population issue. It just magically always happened on a Friday or a Sunday when I'm at work. And so, you know, you got to get that full picture. You can't just have that narrowed tunnel vision look. And we talk about being tunnel vision all the time in EMS and how that can really hurt you. You know, if you're on a trauma call and you get tunnel vision on the guy's blood that's squirting out of his arm, but you're not paying attention to his airway, you know, it could potentially kill your patient. The same way with chems, we can't get tunnel vision on what we're looking at. We need to look at the whole picture. How are we helping everything? So gap analysis, you know, we need to utilize our needs assessment to identify the major needs. We need to determine what resources are already out there. You know, is this something where we just need to connect those resources, or is it somewhere where we need to help build those resources? So like we said, with the example of the homeless population and not, you know, utilizing the ambulance more because it was cold outside, is there already resources out there that we can give him? Can we already, I don't know, maybe there's a support a homeless population where they send out blankets to them and we just didn't know it was there? Or do we need to create that gap or that bridge and create the program, like I said, where the old ladies at the nursing homes make blankets for those homeless populations? And so that's where we need to determine what we're doing. Once again, stuff to think about. What is our target population? What is our overall goal? What can we change? There's going to be things that we can't change. Remember, I talked to you guys about homeless population and kind of in our area. I couldn't change that. I realized that. Some people love living homeless. That's just the way it is. But maybe there's some other things that we can change. What are the barriers? What is preventing us from solving these issues? And what evidence-based interventions can help fill that gap? Hopefully this plays good on this computer. If it ends up being choppy, just message me on chat and let me know. But this is a good example of agency that helped use their needs assessment to bridge that gap, okay? I'm gonna let it load just for a second so we know it's not gonna break up. All right, here we go. Is everybody not hearing the sound?
I don't hear it.
All right, I wonder if I mute myself if that causes a problem. Let me play it with my microphone on and see if it can hear it. Anybody hear that? All right, we'll do something else here. There's always a way around it. There in your chat, let me go to everybody. In your chat is linked to the YouTube video. Please watch it. We'll be back in like 3.47 minutes. All right, did everybody get that video done? Pretty close. Stephen went and had dinner. All right, I'm just gonna assume everybody got done. So in that video, there was a couple of additional resources that maybe sparked a thought in your mind. Did you guys catch any more that, remember we were asking what kind of resources do you have in your area? Were there any more in that video that you saw that maybe sparked your mind of stuff we need to look for in our community?
The United Way and other places like that that help out.
Yeah, Adam, good. The United Way is an excellent source of information, and they're also an excellent source of help. During Corona, did anybody reach out to the United Way when they needed PPE by chance? Okay, so United Way actually did a thing down here, and I don't know if it was the same everywhere, but where they went around and gathered PPE for healthcare providers, people that couldn't necessarily get resources right away. And so that was a great advantage of having the United Way just for COVID alone. Anything else that people saw on there? There's another big one that I'm looking for.
Dental, like who knew?
Yeah, dental services is huge. You think about it, the better oral care you have overall, the better health care you have. So they identified that as a huge issue in their community. So one that we didn't talk about was food banks. That was one of them that was kind of mentioned. You saw a lot of pictures of the fruit and availability of fresh fruits. And then you don't necessarily think about it, but farmers markets are another great place where people can buy fruits and vegetables for a lot cheaper instead of having to pay them through the stores. So that might be a great resource for your patients as farmers markets open up. Is tell them to go there and buy their fruits and vegetables because they can usually get a better deal. Because fruits and vegetables are not cheap. It's cheaper to buy a Twinkie. All right. Any questions? Any answers? Anything that you guys from tonight have any needs for clarification? Awesome. Just so you guys know, look at what we're doing next week. Like I said, we're gonna try to get the boring stuff out first. We're gonna talk about developing a program next week, and then we will go into cultural competency. Both really good, important things to realize when you move into a community paramedic program. But other than that, it is, luckily for you guys, only 8 o'clock. It's 9 o'clock my time. We're way early, but it's all right. We'll meet up next week and hopefully you guys come up with some. What I ask of you guys for the next week, like I said, we're not necessarily going to have homework, but definitely going to have some things to ask, is go around as you're doing your calls and start identifying some issues within the people's homes that you might identify that maybe possibly that you guys can fix using a community paramedic program. And then my other ask is that you guys start looking around your community at some of your resources, and let's come up with a pretty good list of resources that maybe you didn't realize were out there. Some places that you guys can look is, you know, those boards where they tack up all the things and you can tear off deals, call this number if you need this. Sometimes those have some really good resources, as scary as that is. You know, go talk to maybe your senior center, your health department, and just ask them, or even your hospital, just ask them what are some of the resources in our area. If you want to focus on a particular issue that you think is big in your community, then that's fine. I'm not particular, but let's kind of ask those two things from you guys. It's not a lot, pretty simple stuff you can do, just kind of walking and strolling throughout your days. All right. All right. If nobody has any other questions, I'll stay on until everybody, can I email the presentation slides out? Linda, these are copyrighted by Travis. Why would I ever want you to steal this stuff? Yeah, I can probably do that. It's not going to look as cool as mine. It's not going to move cool like mine do, but I think I can print off the PDF versions of them. And other than that, if you guys are good to go, you're more than welcome to log off, and I'll just stay on in case anybody has any questions until everybody leaves. Thanks, guys.
Hey, Travis.
Yes.
So we have a state optional module test next Wednesday
Okay.
starting at 5. So Josh and I both will probably need to be there. I don't know.
Okay, that's fine. Just log in whenever you guys can, and if for some reason you don't make it, we'll like I said, I'm gonna figure out a way to get you guys the videos and the presentations. I think what I'll probably do is upload the videos to YouTube. That way you guys can watch me in 1.5 speed. That's how I watch all my videos now. It saves so much time in life. And then you guys can also refer back to them. I'll probably have them shut off though at the end of this course, just because I created everything in this course and I kind of want to make money off of it too. So
Yeah, you should.
yeah, so
Right.
awesome. Thanks guys.
Thank you.
Yeah.
Thanks, Travis.
Thank you, Travis.